Can everybody see my slides? Can you hear me?
Yes, we hear you well, and the slides are good.
Thank you, Prof. Hi, everyone. I'm Kanyezi. I'm going to be talking about the management of uncomplicated UTIs and uncomplicated recurrent UTIs, sorry, with a specific reference to an article that was in the British Journal of Urology in June this year. So I'm just going to start off with a few definitions. And I just thought maybe we would just do a quick review on the pathophysiology of UTIs, and then go into the actual recurrent UTIs and our current recommendations, and then end off by scrutinizing the article from the British Journal of Urology, and then conclude from there. So basically, urinary tract infections, it's basically an inflammatory response of the urothelium to bacterial invasion associated with bacteria and pyuria. And we all know bacteria is bacteria in the urine, and can be clinically significant depending on, and also depends on the number of bacteria in the specimen. Pyuria is white cells in the urine, can be infectious or non-infectious. Basically, an infection will result, will be a result of the interaction between the pathogen and the host. And a successful infection depends on the virulence of the bacteria, the inoculation size, and obviously the host defense mechanism. Urinary tract infections can be defined by site, commonly cystitis and pyelonephritis. And we all know cystitis, clinical syndrome of dysuria, frequency and urgency, and pyelonephritis can present acutely or chronically. UTIs are also defined according to anatomical or functional status of the urinary tract, and of course the host. And that's when uncomplicated and complicated comes into play. Uncomplicated UTIs are infections in healthy individuals with normal functional and structural urinary tract infections, and usually a short course of antibiotics is enough to treat these infections. Complicated UTIs, infections in people with factors that increase the chances of acquiring UTI bacterial infections and decrease the efficacy of treatment. So urinary tract structural or functional abnormalities, hosts with immune compromised bacteria with increased virulence or resistant bacteria, and male patients also classified as complicated UTIs. Urinary tract infections, we can also define them according to relationships to other UTIs. So a first isolated UTI, a patient who's never had a UTI before, or only has one remote UTI, and the UTI resolves and the patient is fine. Unresolving infections, infections that are not responding to any antimicrobial treatments, and we find that the same organism persistently growing in the urine, MCNS. Recurrent infections occur after documented successful treatment of the UTI. There can be reinfections with a new event, new bacteria that infects the urinary tract. They can be bacteria persistent. So these UTIs are caused by the same bacteria, and usually there's a foci in the urinary tract that harbors the bacteria, such as a stone. Routes of infection of UTIs, most commonly ascending from a bowel reservoir through the urethra up to the bladder. Pathogens adhere to the vaginal mucosa and perineum, and then up to the urethra. 50% of these infections can extend into the upper tract, and when they go up the urethra, the ascent can be increased by any process that interferes with normal peristalsis. So if the patient has got urethral reflux, the patient has got intrarenal reflux, that can cause increased infections. Hematologic is uncommon in normal patients, but usually a Staph aureus infection. Sorry, can I ask the person who's got their mic, just switch off their mic? And then we've got lymphatic spread, which is direct extension from adjacent organs. So common pathogens. So you have E. coli, which is the most common pathogen that causes UTIs. And other gram-negative and gram-positive enterobacter, like Klebs, common in causing UTIs. So we also have fastidious organisms. These are organisms that grow in special cultures, like TB, chlamydia, not very common causes of UTIs. E. coli, like I said, one of the most common causes of UTIs. It accounts for 80% of acquired community-acquired UTIs. So E. coli, we have uropathogenic E. coli, which infects the tracts. E. coli has the ability to infect urinary tracts through virulent factors. So you have factors such as bacterial adhesant molecules. So the bacteria can adhere to the mucosa of the bladder and other organs of the urinary tract through adhesion molecules. So the most common ones are papillae, type 1 and P. papillae. Type 1 papilla is more adheres to the bladder, and P. papillae to the kidneys. So that's how they adhere. And that's the most important step of the bacteria coming into the system. Another way virulent bacteria are virulent is because they've got an polysaccharide capsule. This polysaccharide capsule basically helps the bacteria to be protected from phagocytosis from the host immune. And the bacteria also produces toxins like hemolysin B, which creates pores in the host cells so that the bacteria can infiltrate. The host itself as well is receptive to bacteria. So in terms of the host, you have vaginal mucosa, which is susceptible to urinary tract infections. And there's found that there's some genetic traits that are familial that patients have, which could put them at risk of UTIs. Hormonal changes, it's been noted that decreased estrogen can increase your risk factors to recurrent UTIs. Certain blood groups as well, patients with certain blood groups have been found to have increased UTIs. And vaginal fluid, so bacteria likes to adhere when the surface is nice and moist. So adherence to the vaginal fluid increases UTIs. The bladder itself has got uroplakin molecules, which is how the bacteria actually enters the bladder mucosa. The bladder itself, and then once the bacteria is inside, the bacteria then grows and forms biofilms. Biofilms, again, also allow the bacteria to hide from the host immune system and from any antibiotics that can be in the system. But our bodies also as hosts have natural defense mechanisms. Our natural flora, which is in the vagina, on the perineum, and forms a protective mechanism against bacterial invasion. Urine, so properties of urine itself are protective against infections, like the pH of the urine, the osmolarity of the urine. and also protein molecules like Temhol's protein in the urine acts as bind the leukoplakin in the bladder to inhibit adherence of the bacteria. The bladder itself is a natural defense mechanism against bacterial invasion, in the sense that it empties, so that allows bacteria to be removed, and properties of the bladder in terms of immune system. This is where your innate immune system first gets activated. So now to recurrent UTIs. So in terms of recurrent UTIs, so recurrent UTIs can be complicated or uncomplicated, but today we're going to focus on uncomplicated. And basically, we call them recurrent when you have a frequency of 3 or more UTIs a year, or at least 2 UTIs in 6 months. They can include the upper tracts and the lower tracts. But once the upper tracts are involved, they're usually complicated. Uncomplicated UTIs are very common. Young women, they peak between the age of 20 and 29. And then there's a second peak again for elderly women over the age of 65. So I just wanted to also just go according to current management, review that, and then we get into the actual article that we must scrutinize. So currently, when we manage UTIs, we first evaluate the patient. This basically evaluation is to focus on preventing recurrence by identifying risk factors and changing patients' behavior that contributes to the recurrence. So you want to eliminate any overt anatomical or functional abnormalities that you may find in your assessment. So firstly, like with any patient, you can take a medical and a surgical history. So that's where you can identify patients with risk factors such as diabetes or any causes of immunosuppression, any surgeries such as pelvic surgeries, any history of radiation to the pelvis that can in fact make the patient have increased risk of recurrent UTI. And with that, you also have to, like I said, the risk factors. So this table here just shows us the most common risk factors for young ladies, premenopausal, and then postmenopausal ladies for recurrent UTIs. So the most commonest risk factors: sexual intercourse in young ladies. Older ladies, mainly it's because of the decreased estrogen. Second thing you're going to do, physical examination. Once again, this will allow you to assess the patient for any overt anatomical, functional abnormalities. So your physical examination involves general examination, abdomen. You want to palpate if there's a full bladder. And with that, if you see a full bladder, you can do post-void residual volumes and maybe a flow rate. And then you also included in the examination is a pelvic exam that's going to obviously allow you to assess any risk factors in terms of fistulae that you might find during the examination, prolapsed organs, and then laboratory tests. So every UTI needs to be confirmed on laboratory tests. So you need to do microscopy and culture to actually prove the UTI. You need to get sensitivities as part of your evaluation, so you can give culture-directed antibiotics. Imaging and cystoscopy. So these are only indicated if your patient has got high risks for UTIs, and you're suspecting the patient might have anatomical or functional abnormalities that need to be worked up. So management of UTIs, we first have to start off by treating the acute infection that the patient presents with at the time. This is just the table from the European guidelines with recommended antibiotics in terms of treatment of UTIs. So first line antibiotics, alternative antibiotics, and when you're in a region where there's resistant patterns for E. coli, there's recommended antibiotics for that. And of course, men can have UTIs. So you also have recommended antibiotics for men with UTIs. Second to that management is behavioral modification. So in terms of this algorithm, they say that behavioral and personal hygiene measures have been suggested to increase UTIs. But according to the guidelines, studies have been done and they show lack of association between behavioral modifications and increased risk of recurrent UTIs. So behaviors such as when wiping and going to the toilets, wiping from back to front. So those kinds of behaviors have actually not been associated with UTIs. So they generally don't recommend that you counsel the patient too much on behavioral modifications. Non-antimicrobial prophylaxis, so hormone replacement. So they speak about hormone replacement in terms of estrogen, and estrogen per vaginal has been studied the most as compared to oral estrogen. According to the guidelines, vaginal estrogen, it has been shown to decrease the rates of recurrent UTIs, but not significant enough to actually recommend that patients be given the estrogen. Immunoactive prophylaxis. So they found that immunoactive prophylaxis does actually help decrease recurrent UTIs, especially in patients with recurrent UTIs, and they found that it prevents recurrent UTIs. Probiotics, they found that there's actually no benefits in recommending the use of probiotics for patients with recurrent UTIs. Cranberry products have also been studied in small studies. There's no large studies that can actually assess whether these products actually are beneficial. So they've actually said that patients could be advised to increase the intake of cranberry products, but obviously there's going to be increased calorie intakes, and if patients don't mind that, then there's no harm. Dimenson is shown to be effective, to be as effective as some antibiotics, including nitrofurantoin, in preventing UTIs. But once again, there's no significant evidence, but it is recommended that it could be used in a setting of a clinical trial. So installations of antibiotics into the bladder. So there have been studies that have been done with bladder installations, but they found that there needs to be more large-scale trials in order to assess whether these installations can be beneficial to patients. And antimicrobial prevention obviously would be the next step. And we have 3 different types of ways we can give antibiotics to patients with recurrent UTIs. That is continuous low dose antimicrobials, post-coital prophylaxis, or self-diagnosis and self-treatment. So continuous low dose antimicrobials, microbials that are given to patients on a long-term basis between 3 to 6 months. These antibiotics should be given based on the urine MCNS results. And the only issue with this is that after you've given the antibiotics for that long period of time, there's no actual preventative measures after. And they found that some patients could have recurrence in terms of UTIs, but it's been found that it's the most effective way to prevent UTIs. But obviously, it comes with the side effects of long-term antibiotic use in patients, and such as GIT side effects, which some patients might not tolerate. Post-coital prophylaxis, like we have previously said, that sexual activity is one of the risk factors for recurrent UTIs. So those patients that have been found to have UTIs post sexual activity can be treated with post-coital prophylaxis, especially patients that have a history of UTIs and they are currently pregnant. So those ladies would have an increased risk of getting post-coital UTI. So it would be recommended to give them the prophylaxis. So this is a single dose antibiotic that you take just after the sexual intercourse. And then self-diagnosis and self-treatment. So with this strategy, patients who are compliant and patients who understand, you can counsel the patient. So the patient monitors themselves. Once the patient can feel signs and symptoms of a UTI, you can even ask the patient to buy urine dipsticks at home. They test their urine and assess themselves to see if they've got UTI, and the patient can then start themselves on a short course of antibiotics. But according to the guidelines, this should only be done if the patient is far away from a health professional. For instance, like if the patient is traveling, then it would be a recommended way to treat these patients. So as per the guidelines, after assessing or the information, the recommendations basically say that when evaluating a patient, urine culture is essential. The use of routine imaging and scopes is not recommended, only in patients who have risk factors. Like I said, behavioral modifications like voiding after intercourse, increased water intake is not really recommended in terms of counseling to the patient. The use of estrogen replacement to postmenopausal women, like I said, there's been some benefit and there have been some small trials, but the recommendations are also, it's not really recommended. Excuse me. Immunoactive prophylaxis to reduce UTIs in all ages is recommended, and patients can be counseled about this, and patients can be given immunoactive prophylaxis. The use of antibiotics, whether post-coital or continuous, is strongly recommended. It's only if antimicrobial, non-antimicrobial interventions have failed. Patients on good patients with good compliance can be counseled about self-administration of antibiotics. With that said, these are the current recommendations as per the EAU, and this is what we would currently recommend in terms of management. But as part of the talk today, we wanted to review a specific article in the British Journal of Urology that specifically looked at the management of uncomplicated recurrent UTIs. So this article, like I said, was from the British Journal of Urology, which was published in June this year. And basically, it was a narrative review that investigated publications that deal with recurrent UTIs. The objective basically was simple, just to discuss optimal management of recurrent UTIs in women. To start again from the evaluation. And as I talk, I'm just going to compare as to what we're doing now. So in terms of imaging and scopes, just like our current European guidelines, imaging and scoping is only for patients that have suspected complicated UTIs, and a urine culture is needed in order to diagnose a UTI. The evaluation should be directed towards behavioral aspects. That was the one thing that they also highlighted in the article. And in terms of the evaluation as well, they also said that it's important to assess fluid intake as part of your evaluation, because they have found that the literature for fluid intake is significant. And they found that patients who have a fluid intake of less than 1.5 liters a day, if they increased fluid intake, they had significant decrease in UTIs. Avoiding diary, just to ensure that the patient is voiding well and there's no residual. And once again, if there is any residuals, you can always add a flow rate. They also spoke about RNA sequencing. So this is a new novel technique. And they found that through the literature, when they assessed patients who were diagnosed with urinary tract infections with RNA sequencing, they found that the diagnosis was more specific, and more patients were diagnosed, and they felt that it should be something that's added to routine workup, but the only problem that it's not easily accessible. As part of the evaluation, they also did...
just a little bit beyond time. I don't know if you can perhaps wrap it up shortly.
Okay, Prof. Okay. So in terms of evaluation, they also noted a nomogram from one of the papers that they evaluated, and they found that on this nomogram, the nomogram basically has the ability to predict patients who will have recurrent UTIs, and the predictability of that was quite significant. In the management, they did specify and highlight that behavioral changes, anti-adhesive treatments, anti-septic treatments, and topical estrogens and immunomodulations were very to them significant in the management of the patients. I was going to go through all the specific managements, but just a quick one. In terms of treating acute episodes of UTIs, they just added that fluid intake was important from the reviews that they had done, and the addition of non-steroidal anti-inflammatories also decreased the frequency of UTIs. They spoke about phytotherapy and shorter treatment durations. Those two basically thought that it would help to eliminate antibiotic resistance. And non-antibiotic strategy, behavioral changes, like I said, they highlighted the fact that increased water intake from the reviews that they had significantly influenced the frequency of recurrent UTIs. Sexual activity, hypothermia. They found that ladies who were cold had a high frequency of UTIs. Anti-adhesive treatment, basically treatment that reduces bacterial adhesion to mucosas. They found that the D-menzone and the gag layer substituents had a significant decrease in patients who were given those treatments, had a decreased frequency of UTIs. Antiseptic treatments. Overall, the antiseptic treatment didn't really influence the frequency of UTIs as much as antibiotic treatment. And then they also spoke about estrogen. And as I alluded from our guidelines, the guidelines don't really specifically say that we should recommend vaginal estrogen to patients. But according to this article, estrogen vaginally significantly improved the frequency rates of recurrent UTI. Immunomodulators. So they also found that immunomodulators, just like our recommendations, also significantly improves the frequency of UTIs. antibiotic prophylaxis, just like our guidelines. They also do recommend post-coital and continuous prophylaxis, but they had also added that intravesical installations actually significantly decrease frequency of UTIs, which was the opposite from the findings on the guidelines. The one thing that they also just highlighted was experimental strategies, which our guidelines obviously have not explored yet. So the use of probiotics, they felt that was a dramatic improvement in frequency of UTIs. And then the novel treatment of fecal microbiota transfer, where basically microbials from a healthy young patient are transferred in the form of capsules or enemas into patients with recurrent infections. They found that these patients, after getting these capsules or these enemas, had decreased frequency of UTIs. They also have spoke about phages, bacteriophages, which are viruses that infect bacteria. So these viruses are given to patients, and the bacteria is killed by the virus. So when they assessed this, they found that bacteriophages, comparing to antibiotic treatments, they actually had equal results. With that said, they even commented that this could be the next step to replacing antibiotics, the phages themselves. This was a table that I just put together to compare the different notions that our guidelines and this article had put together. Most significantly, the behavioral modifications that they felt were significant, quite significant, the addition of NSAIDs and the experimental strategies. So in conclusion, though we don't quite still understand why we have recurrent UTIs, we just need more research towards that. But the article did say that these novel treatments could be the future solution in managing patients with recurrent UTIs. But unfortunately, more research still needs to be done. So there was no actual proper guidelines or conclusion in terms of a way forward for treating these patients. But we just know that those novel treatments look like they can be beneficial in the long run after some research. So for now, I would say that we stick to the recommendations that we have as per the guidelines, and wait for some new studies that better give us results for the new novel treatments that were described in the article. Thank you.
Nkanyezi, thank you very much for a very well put together talk. I'm just looking around to see if there are any questions. Just to clarify on those guidelines there, the word immunoactive prophylaxis, is that referring to things like D-mannose? In other
yes.
words, they are. Yes. Okay.
Yes.
Just waiting for some hands or anything. I suppose my experience of this topic is that it's relatively poorly managed. You have quite a lot of morbidity in patients, particularly postmenopausal women who get, I won't say mismanaged, but undermanaged, and have quite significant long-term symptoms. And I think we as urological surgeons, although it's not as the forefront of our mind, I think we have a big role to play in managing this cohort of patients in a better fashion. Once we've excluded any organic pathology that can be managed, then we certainly need to still remain very involved in their care. Just looking for any other hands, not seeing anything, and we're a little bit over time. But Nkanyezi, thank you very much for your hard work to review that article and to summarize this important topic. We'll meet again next Friday. Thank you very much.
Thank you, Prof.